Hi, my name is Cameron. I'm a junior doctor working in Queen's Hospital. So today we're going to go quickly over X-ray within 10 minutes. So first thing, when you look at X-ray, look at the name to see if the right patient. It's very important, especially when it comes to the work. Many times you look at the wrong X-ray, wrong patient, do a chest drain, and it's the wrong patient, wrong lung, and then it causes a lot of complications. And then you look at the quality of the X-ray. You look at the penetration. You look at the angle, is AP or PA, and you look at the rotation. So, do anyone know how to look at the rotation of the X-ray? So you look at the spinous process, okay, and then you have the medial aspect of the clavicle. So the spinous process has to be equidistant to the medial aspect of the clavicle, so that you know it's a good rotation of the X-ray. And why is it important to know if it's an AP or PA X-ray? Anyone know? Do you know what I mean by AP and PA? Yeah. Okay. Yeah. So when the X-ray is taken from anteriorly, so the beam's coming from in front of you. So the chest itself, the heart, it looks bigger. So when it comes to looking for cardiomegaly, AP becomes very difficult to assess if it's cardiomegaly. So first thing when I do is look at X-ray, I look at the airways. So A, B, C, D, E again. Airways, you look at the airway, is there any tracheal deviation? Then you look at lung fields. So you look at the costophrenic angle, you look at the apical aspect, and to see if there's good inspiration. Then you look at the heart itself. So you look at the left atrium, the left ventricle, you look at the aorta here, and then next you look at the diaphragm, you look at the costophrenic angle. If there's any air here, then it's problematic. And then you look at E for everything else, look for lines.
Is this the normal X-ray?
Yeah, this is the normal X-ray. So here you look for line. This is the ICD. Does anyone know the difference between ICD and a pacemaker is?
I know the pacemaker is father when the heart is blocked, we're putting inside, but ICD
Is for when the heart stops. It does a.
is temporary pacemaker like?
No, it's for intracardiac device. Okay. So when your heart stops, it gives up pulse, and usually you see this big extra lead here. So that's the ICD. So when you look at X-ray, first thing you look at is the black areas is the areas, all right. And if there's any white patches, this is called consolidation. So this is where you have, for example, consolidation could be edema, so fluid. It could be cancer, so cells cause consolidation. It could be hemothorax, or blood will give you consolidation, or you can have pneumonia, so pus, inflammation, that will give you a consolidation. So it will give this fluffy appearances. So anything that doesn't look normal, like the previous one, where it's black and pitch black and it's quite nice, when you see this, you'll be like, okay, there's consolidation. Then you look at the clinical picture, what they say is, if they have temperature, or if they have weight loss, you look at cancer. If they have coughing, then you look at infection. And so here you have, anyone want to guess what this is?
Scoliosis.
So here you're missing this whole field.
Is it pneumothorax?
No, it's a consolidation. So this is a right lower lobe consolidation. How about here?
Yeah.
Left lower lobe consolidation. And here you have interstitial pneumonia, where you have atypical pneumonia, mycoplasma pneumonia. They cause reticular patterns in the, here you can see the reticular patterns. So this is interstitial pneumonia. And the next thing, you have the cavitary lesions. So these are like well demarcated lesions. So these are like, so can you guys see? So as you can see, these are well demarcated lesions, and they vary in sizes. And these, because X-rays are not very definitive, they give you just a picture, and it says something's wrong here because of the consolidation. And here you can see there is a consolidation here, and here you can see lymphadenopathy. And so this is primary TB. So in the questions, primary TB is one of the very common ones to be asked. So this X-ray, primary TB is more in the medial aspect of the chest. And then when you have a post primary or reactivation to TB, so after when you have as a child you have TB and it comes back, it comes to the apical region, and can you see the white consolidation on this area? So that's one of the things that you have to look for in the vignette, is it primary or is it secondary TB? And after TB, what happens is that if you have it, the end process is fibrosis, and then sarcoidosis. Who can tell me about sarcoidosis? Yes, and so this is the picture that you're looking for. You're looking for this lymphadenopathy, and there's constellation around here. And so here we have it says here, pleural effusion. So pleural effusion, what is it?
Is it down there?
Yeah, but what is it itself? What does it mean?
Even in the pericardial?
No, not pericardial. No, it's peritoneum.
Pleural is space. It's space between the lungs and the pleura.
Yes. And when you have fluid build up in the space, what it does cause sometimes, it causes a mediastinal shift, because you have more fluid there than the mediastinal organs, so the trachea will deviate to the left side. So that's one thing to look for. And to know that if this is a pleural effusion, you get this meniscus. So when you see a meniscus, it means it's a pleural space. Okay, and then you have atelectasis. This is a complete atelectasis. There's a block of the bronchus, and the viscera and parietal pleura, they all go in, and the lung collapse inside. All right, and here, what happens to the trachea and the mediastinum? To which side?
Affected side.
To the affected side, yes, because you have no pressure here, so it just goes there. And here, do you know what this is? So consolidation would normally give you like a patchy area, but can you see here, this is a well demarcated area. It's very precise. So here it is a right upper lobe atelectasis. Okay, so this is called a S. Sulcus-Golden sign, where you have complete. This is the S here. And in this gentleman, he had a tumor around this area that caused the apical part of the lungs to collapse. And here, what we have here is a normal X-ray. And what kind of X-ray do you have here? So this is a common.
Because the diaphragm is like flat.
Yeah, diaphragm's flat, hyperinflated. You can see the apical area. So this is emphysema.
What is?
Emphysema. And pneumothorax. This one is very important to know in X-ray, because it becomes quite difficult to see it sometimes. But can you see here, you have, what is pneumothorax in the beginning? Yeah, so in between the parietal and the visceral area, there is a air, and usually caused by trauma, or it could be spontaneous pneumothorax. And you can see here, there's a well demarcated visceral layer. And then you have tension pneumothorax. So this is a medical emergency. And why is it a medical emergency in tension pneumothorax? Hmm?
There's lots of breath sounds.
Yeah, but it's one sided. But what it causes, because you have loss of, you have air in this area, it results for the like trachea and everything to move towards the left side, and it compresses the cardiac and the whole organs there. And so it's a medical emergency, so you need a chest tube. So do you know where you would normally put it? And what else? Anything else? So even like when it comes to medicine itself, if you have a pneumothorax and you don't really see it in the X-ray, there's another way you can do a repeat X-ray to see it. So you ask them to have a repeat X-ray when they expirate. So when they're breathing out, so the pneumothorax itself wouldn't change in size. So then you will know that this is a pneumothorax. And this is cardiogenic edema. So here you have a congestive heart failure, and that by itself will cause bilateral pleural effusion. But you have different stages of cardiogenic failure or cardiogenic edema. So here you have interstitial edema, and then you can have alveolar edema, which is more consolidation, more patchy. And here you have nice pleural effusion. And you can also see the heart itself. So here you can see the heart is enlarged. It's 2/3 of the diaphragm. So when it's more than 2/3 of the diaphragm, it means that it's a cardiomegaly. And then you have non-cardiogenic edema. So here, normally the heart size is normal. It could be normal, but usually you'll see in the vignette itself. And itself, you'll have peripheral consolidations. So you have this patchiness, and this can be caused by, for example, here this patient had drug overdose, cocaine overdose, but you can have RDS, or you can have infection itself, or cancer itself will cause non-cardiogenic interstitial edema. And I think this is it.
So we'll just quickly go over it once more. Okay, there's a few things, basic things, just more focusing for Plab. Okay, so that's just sort of a general overview. So Dr. Miru just...
No, he done the job, but just those few slides that...
What do you,
Huh?
what do you think?
Oh, sorry. There's just few slides that comes up in your exam, isn't it? Remember, you said hyperinflated, those things. Sarcoidosis, remember bilateral lymphadenopathy? Right. So he's got very good slides. I didn't see it earlier, so I was thinking I'll just tell you. First thing, basic, yeah? Remember, I'll think of it like a student. Black, what color this should be? What color? Black. Air is black. Air is black. White means some kind of liquid. Very white mass. So goes up. Doesn't make sense. Now, if you see white, look at the structure. Remember, he said demarcated. He used big words. Let's break it down. How does it look like? Does it look liquidy? Like, is it circulish? Is it everywhere? Fluffy? Where is it? So look, is it black? Is it white? Okay, where is the white? Okay, so let's go over. Does this work? Oh, I don't know how to use it. Okay, so don't worry about that one. Consolidation means liquid. Where is the liquid? Is it at the bottom? Is it here? Or is it there? That's what gives you heart failure. Your heart isn't working, so you're gonna get bilateral. If you see one-sided, it's more one-sided localized. So those things gives you answers. In Plab 1, we need to get these simple stuff right. So now let's look at something that might be helpful. Okay, so this one, what can you see? What's happening here and what's happening there?
Too much air over there.
Too much air over there. Now it makes sense, doesn't it? Too much air and too much liquid there. Doesn't make sense. So there is some kind of pathology here. Yeah? So what was this slide that he mentioned earlier? What was it? Do you remember, guys?
It's a straight line in pneumothorax because there's the oil.
Okay, so a few things, yeah? So to find out, so some people said pneumothorax, some people said pneumonia, everything, yeah? So let's find a pneumonia. Okay, let's use this one, yeah? Pneumonia, can you see these angles? Are they clear? Can you see them?
Yes.
Can you see this angle? It's a little bit fluffy here, isn't it? So there are some kind of thing going on. So look at the angles, okay? If the angles are covered with liquid or not, okay? Then the next part you look at is here, hilar region, if it's there. The third you think is look at that fluffiness if it's everywhere. So when you listen to people's chest, you say, oh, I can hear crackles. Where about the crackles? Right upper. Then do an x-ray, you see it right upper, then it matches with your clinical diagnosis. Does it make sense? That's how it works. So, so let me show you for example, this one. Look at that. That is he got a very good picture. This is a prime white lymphadenopathy bilateral. Can you see that? There, can you see hilar region? These are the hilar region, and they're both fluffy. So they will literally give you this and say, what is it? And they might give you a few diagnoses in the history and everything else, and we think of sarcoidosis. Remember I told you in x-ray bilateral lymphadenopathy, and there you go, bilateral. But this one, normal person, they might also think, oh, it is everywhere, isn't it? It looks everywhere, but it's more dense. Can you see the color? Yeah. Color. So look, you have to go with the history. You can't have an x-ray without a history. You need to have a history and then look at the color, then you go for sarcoidosis. You'll probably see high calcium, something like that. Yeah. So these are basic. Otherwise, everything else he mentioned, I think where's the pneumothorax picture? because okay, hyperinflated lung, yeah? One of the, someone mentioned, but you haven't seen it. Look at the diaphragm, straight, hyperinflated. So diaphragm meant to be like this. Look, it's straight. You said in Plab 1 it came up, so look, that's straight. COPD. Yeah? So he said emphysema, emphysema comes under it.
And the resonance is hyperresonance, huh?
Do you know what hyperresonant means?
Too much air.
Too much air.
Too much air, so if you're doing
Like
percussion,
talking, yeah, this one.
it will be making a hyper noise.
Hyper.
If you have air inside a balloon, yeah, and it make it, what kind of noise will it make? Hyper resonant. If I have a balloon inside, put liquid in there, water in there, and just on top of the water, if I tap it, what kind of noise will it be? Dull.
Dull. Okay.
So
Dull.
lung is our balloon. If you put water in that, press it, dull. If I put air in that, hyper resonant. So if you have pneumothorax, yeah, it's air now because that lung is collapsed, everything is air. So if you percuss, it will be hyper resonant. Does it make sense?
Yeah, this one. Thank you.
Now this one, pneumothorax, you can't see it. This is, I don't know how you guys said this pneumothorax. I can't even see anything.
Yeah, it's a very
The
fine
line,
line.
it's a fine line.
Oh, mashallah, you can see the fine line. Okay, you can see it here.
Yeah, simple pneumothorax.
Yeah. So it's very simple pneumothorax. And you see the line here, you will see one side. How do you know it's pneumothorax is easy? Yeah? People think pneumothorax is hard, it's not. If you look at this diagram, if you look at the proper picture, you can see the line. Basically, you will see the other side, it will pitch black. And this side will be normal color. There's another way to find out. You know this whitish line, yeah? It should be everywhere, really. It should go everywhere. So you can follow these lines until where does it stop? It should go all the way to the top. If it doesn't go all the way to the top, it's a problem. It might stop here. Then look at this side. Is it really dark? Then it's pneumothorax. Right?
And for this one more thing very important for exam is that you need to know simple pneumothorax and tension. For simple pneumothorax, you do chest X-ray. This tension, you can't do chest X-ray. It has to be a clinical diagnosis based on examination and patient findings. So if it's tension, clinical diagnosis, put a needle straight away. Don't do X-ray, you'll kill the patient.
And what's the examination? Look at that. Tension pneumothorax here. He was just telling you about. Can you see the tension? Remember tension. Tension is push. It's pushing the pipe to the other side.
And don't forget cardiac tamponade and tension pneumothorax.
Yeah.
Very close, huh? But hyperresonance, absolute breath stand on that.
But the cardiac tampon is a triad.
This is triad, yes.
Yeah, triad.
The three of them.
Yeah, second triad.
If one of is missing, then it's tension.
So this is tension because it's pushing it. This one is no tension because it's straight line, but you can see the line in a proper picture. The other side will be pitched black, yeah? Remember, it's black. Black means air. And then that's it. Cardiogenic edema, you can see both. And that's it. Yeah?
Thank you.
No.